Hi, it's my great honor to join this HIV clinical forum. So in the next 20 minutes, what I'm going to update you and bring up some of the practical consideration is about the topic of switching to reduced drug regimen. Here's my disclosure. So there are a number of major reasons why we would like to switch the regimen of one individual. The most important and most critical reason is because that individuals are facing treatment failure, particularly related to the emerging of HIV drug resistance. The other main reason is related to tolerability or toxicity, and may also related to drug interaction, or because of the cost issue and we want to bring the cost down with the next switching regimen, or because we identify hepatitis B co-infection. And also the other reason is the comorbidity of pregnancy. Last but not least, one of the reasons is because the individual prefer to have more simplified regimen for the long term. Now, when you decide to switch a regimen in a person with virologically suppressed setting, so what to be considered? The first thing is we have to make sure that we carefully assess the history of the patient about the drug resistance in the past and the baseline drug resistance profile. You have to see whether what type of comorbidities, maybe more than one, that this individual facing right now, either chronic kidney diseases, cardiovascular diseases, osteoporosis, dyslipidemia. And be careful about when you consider to switch, whether we have to make sure that we're not going to create another issue of drug-drug interaction that may compromise the treatment efficacy or to enhance toxicity within that individuals. And if you identify the patient does have hepatitis B co-infection, the next regimen have to be sure that 2 anti-hepatitis B active nucleosides are included or need to be added. There are a number of clinical trials addressing switching regimen in a person, in the virologic suppressed setting into a single tablet regimen. So this is to simplify the regimen. So among these 3, you see that these 6 clinical trials reported, 2 of them are dual drug therapy. So I'm going to focus the rest of my talk mainly on oral dual drugs switch regimen. And we have seen in the past few years or so that there's a trend to work further reduction a number of drugs in the regimen from 3 to 2 drugs, and also the reduction in the dose frequency, in this case using injectable long-acting ARV, or even working toward implantable long-acting ARV. So why we have to go for dual therapy as a switch? There's a potential to reduce side effects, less number of pills. There's a potential to reduce toxicity, particularly the long-term toxicity. reserve future options, and cost saving. That's also a key consideration. Now, when we're talking about true drug regimens, people that have been taking care of patients for decades might memorize another negative outcome of true drug regimen, because in the past 2 decades, when we're talking about true drug regimen, it's a 2 nucleoside or 2 nodes dual therapy. So we should not recommend this type of approach anymore, because the potency is not good, durability is poor. So now we're talking about, after 2017, so we're talking about dual therapy that at least one of the ARV in that regimen containing dolutegravir. Why dolutegravir can be used as a dual therapy? There's 2-3 reasons. The first one is the drug class in this drug class, integrase inhibitor, is the most potent drug class among others. And you can see that this comparison of monotherapy up to 7 to 14 days of treatment. So this is the, you can see that in this, I highlight in this box, you see that almost all except elvitegravir be able to achieve more than 2 log viral load suppression within the first to second weeks of monotherapy. So it's very, very potent drug. More importantly, this class also have high genetic resistance barrier. So you see that among these 4 integrase inhibitors, dolutegravir and bictegravir, based on one of the meta-analysis report from several phase 3 clinical trials, the drug resistance rate of that trial is only 0.1%. There are 3 dual therapy has been approved by the FDA. So DTG, 3TC, DTG rilpivirine, and the long-acting injectable cabotegravir rilpivirine. Now, I'm going to share with you the evidence base of how efficacious, or including effectiveness of these 2 oral dual therapy. I start with the first one, DTG 3TC, TANGO study at the randomized control study, phase 3, and the real-world effectiveness cohort. And this is the TANGO switch study, switching from DTG 3TC as compared to the continuing tab-based regimen, the 3-drug regimen. So this is the primary endpoint at 48-week result. You can see that a comparable snapshot analysis of percentage of patients with viral load undetectable below 50 copy. And when you look at non-inferiority analysis, it's clearly that 2-drug DTG 3TC non-inferior as compared to tab-based regimen. And recently at Glasgow meeting, so a few months ago, I believe it's November, you see that this is the update report of TANGO at 2 years follow-up. Again, this is in blue, the 2-drug regimens, 86% as 2 years follow-up versus 79% of tab-based regimens. And you see that, again, it's still reaching non-inferiority design. It's very interesting to see this type of widely implemented regimens in various regions. And this summarizes the data of 8 effectiveness real-world cohort, observational cohort. The endpoint of follow-up, time of follow-up is vary from half a year up to 3 years follow-up. And the sample size vary from small sample size, only less than 60, up to, the highest number is up to 250. And you look at how consistent the efficacy or effectiveness of DTG 3TC in this real world cohort is above 90% and up to 100%. So it's 93% up to 100%. And very impressively that this effectiveness cohort study all show a very low adverse events driven discontinuation and withdrawal rate. So it's from 1.5% to 8.5%. So the 8.5% actually based on a very small number of sample size. And more interestingly, the confirmed virological withdrawal or virological failure is really very, very low as well. So the Gemini actually is not the switch study. This is the long-term. I just put in to give you more information that in the long-term first-line DTG-3TC Gemini study, the confirmed virological withdrawal is 2% compared with the TDF or the TAP base. And when you look at DTG-3TC as switch in TANGO and real-world effectiveness is 0. So it's very impressive that failure rate is 0. And there's no treatment emerging resistance because there's, virological failure confirmed is 0. We also can evidence by this report that the TANGO study that when look at the renal, particularly proximal renal tubule biomarker, when compared to TAP-based, we're not going to see much of difference. In terms of urine biomarker, it's very comparable between the two groups, DTG-3TC versus TAP-based regimen. But in terms of creatinine increase, so DTG-3TC did a little bit elevated higher compared to TAP. But if you look at the lipid profile, because TAP associated with dyslipidemia, increase of hyperlipidemia, and you can see that in blue is the dual therapy, DTG-3TC, or the lipid profile, particularly triglycerides, LDL, has been, changed, reduced from the baseline compared to TAP-based regimen, so significantly. So it's this advantages of dual therapy without TAP. Now, what about DTG lepivarine switch study? So this is based on two combined SWIRT 1 and SWIRT 2 study. So the design is very standard in terms of switch in virologically suppressed adults. So adults on stable ART, so either integrase-based, NRTI-based, or protease inhibitor-based, combined with two nodes, have been well suppressed below 50 copies for at least 6 months, no previous virological failure history, no HPV, hepatitis B virus co-infection, no evidence of DTG and the lepivarine resistance. This is a total sample size is 1,000 and randomized into either early switch to DTG lepivarine or continue baseline treatment regimen. And after a year, at week 52, so the control arm will switch, we call the red switch phase, into DTG lepivarine. Now let's look at the long-term results. These just recently published a few months ago, back in November 2020, have showed 3-year results of this regimen, DTG lepivarine. And you can see that at 1 year, the viral suppression rate is 95%, 2 years up to 90%, and 3 years is 84%. And you can see that it's confirmed consistently with the late switch. The switch, when you follow up to 1 year, you have 93 versus 95 in the early switch. And after 2 years, you have 89 versus 90% of viral, undetectable viral load. And also, this regimen, DTG lepivarine, have a very, very low rate of withdrawal from virological failure, or CVW. You can see that at 1 year, less than 1% have to switch or withdraw because of virological failure, and at 2 years, about 1%. There was no DTG resistance detected in this trial. Okay, so I move on. In terms of renal biomarkers improvement, particularly in blue is mean when you look at those patients that pre-treated with tenofovir before switch compared to the group with non-TDF-Pre-switch, you can see that it's a markedly benefit on renal biomarker when you switch to regimen without tenofovir. So it's reduce the biomarker about a third, right? About 30%. So how do the guidelines recommend on dual regimen switch option in virologic suppressed person? So now I summarize the latest guidelines, October 2020 of European guideline on dual switch option. This guideline have mentioned that there are at least 5 2-drug switch option for virologically suppressed people based on the large RCT or meta-analysis. So that DTG rilpivirine, DTG 3TC, boosted darunavir 3TC, and boosted atazanavir 3TC. But this is a smaller sample size. And this one, it boosted darunavir rilpivirine and boosted darunavir DTG has a small sample size. So what they recommend is dual therapy can be recommended only where the viral load has been undetectable previously for at least 6 months and no evidence of 3TC resistance, no evidence of chronic hepatitis B infection. They not recommend monotherapy. They not recommend 2 or 3 nucleoside combination, and they not recommend intermittent or treatment interruption approach. In terms of the DSHS, the US guideline, DTG lamivudine is not recommended in individual with baseline viral load greater than 500,000, but this is for the first line. And similar recommendation for hepatitis B co-infection cannot be recommended. How about the implementation in Asia? So I look around whether this single tablet regimen has been approved in some high-income country in Asia. I would say yes. So DOVATO is a DTG 3TC, and Chuluka, so DTG rilpivirine as a single tablet had been approved in some of the high-income countries in Asia. But all low middle income countries not available. So if we plan to use this dual drug therapy, we have to use a sublet pill as a combination. So I'm not going to go into the detail, but when you prescribe the DTG, please, although drug interaction is fairly minor, but please keep in mind that there's a few items of concomitant drugs that might create drug-drug interaction concerns. So please check before you're using this. Now, before I end, I have a couple more slides. So this is some practical consideration I want to bring up to the audience. That so to use DTG 3TC or to use the DTG rilpivirine as compared to tab-based ART, you can see that if you treating a patient with hepatitis B co-infection, definitely with DTG 3TC, you need another. If you want to use this regimen, you need another anti-hepatitis B virus agent to be added. And if you use DTG lepivaline, you need anti-active, at least 1 or 2, anti-hepatitis B added. 1 or 2, right? And for TAF, this is doing okay because you have TAF combined with FTC, both feel active against hepatitis B, and this will avoid 3TC or FTC resistant. For patient that the patient who have chronic kidney disease with dialysis, only regimen that you don't need to adjust the dose is DTG lepivaline. The rest we have to adjust either the 3TC doses or FTC. So you cannot use a single tablet regimen anymore. You have to split it. So keep that in mind. Food restriction, mainly with lepivaline, that's the limitation issue. PPI co-administer, so that will be a problem with lepivaline regimen. Antacid with alum, magnesium, or calcium. For DTG containing regimen, you may have to make sure that this should be 2 hours before or 6 hours after DTG have been taken. Obesity, if any individual concerned with this problem, be careful that TAF plus DTG or biticavir gain more weight. And interestingly, the data both in men and women that when you combine TAF with DTG in the regimen, the weight increase is more significant. So in conclusions, dual drug regimen as a switch among in this two is that DTG 3TC and DTG lepivaline are effective as compared to 3-drug strategy at a switch options in biologic suppressed person. And long-term data coming up more and more, at least up to 2 to 3 years, shows sustainable viral suppression and very low rate of virological failure and the emergence of drug resistance. Hepatitis B viral co-infection and baseline history of class-specific drug resistance should be assessed and make sure that we get relevant information prior to switch to this dual regimen. DTG lepivaline may be a good option for person with chronic kidney disease on dialysis because we don't need to worry about the dose adjustment. PPI and antacid drug interaction should be aware of when using this DTG-based dual therapy. Long-term impact of DTG-related weight gain remain unknown. So I'd like to thank you very much for your kind attention.